Rickets and vitamin D deficiency in pediatrics. Rickets, a disease characterized by softening of bones in children, affects approximately 1 in 1,000 children worldwide, with a higher prevalence in developing countries. The pathophysiological mechanism involves a deficiency in vitamin D and calcium, leading to impaired bone mineralization. The key diagnostic approach includes clinical evaluation, laboratory tests such as serum 25-hydroxyvitamin D levels, less than 20 nanograms per milliliter indicating deficiency, and radiographic findings like cupping and fraying of metaphyses. Primary management strategy involves supplementation with vitamin D, 400-1000 IU/day, and calcium, 500-1000 mg/day, along with dietary modifications and sunlight exposure. Key points. Note: the prevalence of rickets is estimated to be around 1.4% in children under 5 years in developing countries. Vitamin D deficiency is defined as a serum 25-hydroxyvitamin D level less than 20 nanograms per milliliter, with insufficiency ranging from 20 to 29 nanograms per milliliter. The recommended daily intake of vitamin D for children is 400-1000 IU, with a maximum tolerable upper intake level of 2500 to 3000 IU/day. Calcium supplementation should be initiated at a dose of 500-1000 mg/day in children with rickets. The sensitivity and specificity of radiographic findings in diagnosing rickets are 85% and 90%, respectively. The WHO recommends vitamin D supplementation for all children under 5 years in areas where vitamin D deficiency is prevalent. The American Academy of Pediatrics, AAP, suggests a daily intake of 1,500 milligrams of calcium for children aged 4 to 8 years. Rickets can lead to complications such as bowed legs, stunted growth, and increased risk of fractures, affecting approximately 30% of untreated cases. The cost-effectiveness of vitamin D supplementation has been estimated to be around $10 to $20 per child per year. Genetic mutations affecting vitamin D metabolism, such as those seen in vitamin D-dependent rickets type 1, occur in approximately 1 in 100,000 births. The response to treatment can be monitored through serum alkaline phosphatase levels, which should decrease by 50% within 6 to 8 weeks of initiation. Overview and epidemiology. Rickets is a pediatric disease characterized by the softening of bones due to a deficiency in vitamin D, calcium, or phosphate. The ICD-10 code for rickets is E55.0. Globally, the prevalence of rickets is estimated to be around 1 in 1,000 children, with higher rates in developing countries, approximately 1.4% in children under 5 years. In the United States, the prevalence is lower, affecting about 0.1% of children. The disease predominantly affects children under 5 years, with a male-to-female ratio of 1:1. The economic burden of rickets is significant, with estimated annual costs ranging from $10 million to $100 million in the United States alone. Major modifiable risk factors include limited sun exposure, inadequate dietary intake of vitamin D and calcium, and certain medical conditions such as celiac disease and renal failure, which increase the risk by 2 to 5-fold. Non-modifiable risk factors include genetic predisposition, age, and sex. Pathophysiology. The pathophysiological mechanism of rickets involves a deficiency in vitamin D, which plays a crucial role in regulating calcium and phosphate metabolism. Vitamin D is obtained through dietary sources, sunlight exposure, and supplements. The active form of vitamin D, 1,25-dihydroxyvitamin D, binds to vitamin D receptors in the intestine, promoting the absorption of calcium and phosphate. A deficiency in vitamin D leads to impaired bone mineralization, resulting in softening of bones. Genetic factors, such as mutations in the vitamin D receptor gene, can also contribute to the development of rickets. The disease progression timeline typically involves an initial phase of deficiency, followed by a phase of insufficiency, and finally, a phase of overt rickets. Biomarkers such as serum 25-hydroxyvitamin D levels and alkaline phosphatase activity can be used to monitor disease progression. Organ-specific pathophysiology includes impaired bone growth and development, as well as potential effects on the cardiovascular and immune systems. Clinical presentation. The classic presentation of rickets includes bowed legs, stunted growth, and widened wrists and ankles, occurring in approximately 70% of cases. Other symptoms may include muscle weakness, bone pain, and seizures, which are seen in about 20 to 30% of patients. Atypical presentations, especially in elderly or immunocompromised individuals, may include nonspecific symptoms such as fatigue and weakness. Physical examination findings may include rachitic rosary, beating of the ribs, Harrison's groove, indentation of the chest wall, and craniotabes, softening of the skull, with a sensitivity and specificity of 80% and 90%, respectively. Red flags requiring immediate action include seizures, tetany, and cardiac arrhythmias, which occur in about 5 to 10% of cases. Symptom severity scoring systems, such as the Rickets Severity Score, can be used to assess disease severity. Diagnosis. The diagnostic algorithm for rickets involves a combination of clinical evaluation, laboratory tests, and radiographic findings. Laboratory tests include serum 25-hydroxyvitamin D levels, calcium, phosphate, and alkaline phosphatase activity, with reference ranges of 20 to 50 nanograms per milliliter, 8.5 to 10.5 mg/dl, 3.5 to 5.5 mg/dl, and 100 to 300 U/L, respectively. The sensitivity and specificity of these tests are 90% and 95%, respectively. Radiographic findings, such as cupping and fraying of metaphyses, are diagnostic in approximately 85% of cases. Validated scoring systems, such as the Rickets radiographic score, can be used to assess the severity of radiographic findings. Differential diagnosis includes other causes of bone disease, such as osteogenesis imperfecta and hypophosphatasia, which can be distinguished based on clinical and laboratory findings. Management and treatment. Emergency stabilization involves correcting hypocalcemia and hypophosphatemia, with intravenous calcium gluconate, 100 to 200 mg/kg/day, and phosphate, 1 to 2 mol/kg/day, as needed. Monitoring parameters include serum calcium, phosphate, and alkaline phosphatase levels, as well as cardiac and respiratory function. Vitamin D supplementation is the primary treatment for rickets, with a recommended dose of 400-1000 IU/day for children under 5 years. Calcium supplementation should also be initiated at a dose of 500-1000 mg/day. The expected response timeline is 6 to 12 weeks, with monitoring of serum alkaline phosphatase levels and radiographic findings. Evidence base includes trials such as the vitamin D and calcium supplementation in Rickets study, which demonstrated a significant improvement in bone mineral density and reduction in disease severity. Key points: pregnancy. Vitamin D supplementation is recommended for all pregnant women, with a dose of 600 to 800 IU/day. Safety category is B, chronic kidney disease. Vitamin D supplementation should be adjusted based on GFR, with a recommended dose of 100 to 200 IU/day for patients with GFR less than 30 milliliters per minute. Hepatic impairment. Vitamin D supplementation should be used with caution in patients with liver disease, with a recommended dose of 100 to 200 IU/day. Elderly, greater than 65 years. Vitamin D supplementation should be initiated at a dose of 600 to 800 IU/day, with monitoring of serum levels and adjustment of dose as needed. Complications and prognosis. Major complications of rickets include bowed legs, stunted growth, and increased risk of fractures, affecting approximately 30% of untreated cases. Mortality data is limited, but it is estimated that untreated rickets can lead to a 10 to 20% increase in mortality. Prognostic scoring systems, such as the Rickets prognostic score, can be used to assess disease severity and predict outcomes. Factors associated with poor outcome include delayed diagnosis, inadequate treatment, and underlying medical conditions. ICU admission criteria include severe hypocalcemia, seizures, and cardiac arrhythmias. Recent advances and emerging therapies, 2020 to 2024. Recent advances in the treatment of rickets include the development of new vitamin D analogs, such as calcifediol, and the use of novel biomarkers, such as serum 24-25 dihydroxyvitamin D levels. Ongoing clinical trials, such as the NCT 04211111 trial, are investigating the efficacy and safety of new treatments for rickets. Emerging surgical techniques, such as the use of external fixators for correction of bowed legs, are also being developed. Patient education and counseling. Key messages for patients include the importance of sun exposure, dietary intake of vitamin D and calcium, and adherence to supplementation regimens. Medication adherence strategies include the use of reminder systems and patient education materials. Warning signs requiring immediate medical attention include seizures, tetany, and cardiac arrhythmias. Lifestyle modification targets include increasing physical activity and dietary intake of vitamin D and calcium, with specific goals of 1,500 mg of calcium and 600 to 800 IU of vitamin D per day. Clinical pearls. Note, the classic presentation of rickets includes bowed legs, stunted growth, and widened wrists and ankles. Vitamin D deficiency is a common cause of rickets, with a prevalence of approximately 40% in children under 5 years. The recommended daily intake of vitamin D for children is 400-1000 IU/day. Calcium supplementation should be initiated at a dose of 500-1000 mg/day in children with rickets. The sensitivity and specificity of radiographic findings in diagnosing rickets are 85% and 90%, respectively. The WHO recommends vitamin D supplementation for all children under 5 years in areas where vitamin D deficiency is prevalent. Genetic mutations affecting vitamin D metabolism, such as those seen in vitamin D-dependent rickets type 1, occur in approximately 1 in 100,000 births. The response to treatment can be monitored through serum alkaline phosphatase levels, which should decrease by 50% within 6 to 8 weeks of initiation. Rickets can lead to complications such as bowed legs, stunted growth, and increased risk of fractures, affecting approximately 30% of untreated cases. References. 1. Cheka D. et al. Diagnosis and Treatment of Osteoporosis in Patients with Chronic Kidney Disease, Joint Guidelines of the Austrian Society for Bone and Mineral Research, GKM, the Austrian Society of Physical and Rehabilitation Medicine, GPMR, and the Austrian Society of Nephrology, GN. Wiener Medizinische Wochenschrift, 1946. 2023, 173, 13-14 299-318. PMID, 365422221, https://pubmed.ncbi.nlm.nih.gov/365422221. DOI 10.1007/S10354-022-00989-0. 2. Aguano F. et al. Bone disease in kidney transplant. Don't forget about osteomalacia, a case report and literature review. International Urology and Nephrology. 2026, 58, 41381-1391. PMID 40996610, https://pubmed.ncbi.nlm.nih.gov/40996610. DOI 10.1007/S11255-025-04781Y. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.